So we have Dr. Kameshwar Prasad with us. We are very fortunate to have him with us. So Kameshwar.
Thank you, Dr. Anup. I'm odd man out in this because I'm not a specialist in diabetes. So you have to forgive me for being kind of kindergarten child in the diabetes field, but I'm expert in stroke. So I'm here because I cannot say no to Anup. That's the main reason. And the second reason is that he emotionally blackmailed me. He said, you know, this is Ahuja Bajaj Symposium. So, you know both of them. So I came here to pay tributes to Dr. Ahuja and Dr. Bajaj, both of whom we have very high regards. And we have learned a lot from both of them. And I think they were giants in the field of diabetes. And anything which I know about diabetes is because of them. And therefore, I thought I'll share with you some of my own experience, not necessarily high-fi scientific, but something which we have done and something which I have seen in the literature. So, I'm sure you have heard about the prevalence of diabetes. I'm not going to spend too much time on this. This is National NCD Monitoring Survey, which says 9.3% people above 18 years of age, between 18 to 69 years of age have diabetes. But you can see that urban has 14.3% and rural 6.9%. And similarly, as people grow elder, 50 to 69 years has 21.8% prevalence. Across the state, there is a paper where they show variation, which goes from 5% to even as high as 13.6%. But pre-diabetes is much more, which is, I hope, data which is from ICMR, so must be very accurate data. But I'll tell you something about Delhi, because I met one of the persons, attendees here, who have been part of our study, which we have published in International Journal of Epidemiology called Cohort Profile. So people from Vasant Kunj and Munirka, they were part of it. So I think you will like to know what we found right at our corner. And we started with 16,000 households. And basically, finally, 7,505, which is 61.3% of people visited AIIMS personally and got tests done, and which is not a bad degree of cooperation. People had warned me that, you know, in India people don't cooperate, they won't come for a checkup, but that Vasant Kunj people have proved everybody wrong. And they underwent a number of tests. I'm not going into details of this, but you can see how many tests we have done. And even including dental, blood investigations, carotid Doppler, ECG, echocardiography, and neuropsychological assessment, and 2,600 MRI. So nobody in India has so many MRIs on community dwelling people who are otherwise fine. So one of our participants is here. He said, myself and my wife have also undergone MRI. So we have MRI data of otherwise normal people. One paper has been published, something more will be published very soon. So how did we define diabetes? Fasting glucose more than or equal to 126 milligram per deciliter and hemoglobin A1C more than or equal to 6.5%, or self-reported use of anti-diabetes. You know, many people will have less than this because they are taking medicines. And we define control of diabetes as HbA1c of less than 7%. So with this definition, look at the data we got. We had overall 38.4%. So they are 50 years and above. 38.4% have diabetes. Males have more diabetes than females, and that is global data, but different from the data of ICMR, if I remember correctly. Age group 50 to 60 have 33%. As you go to 60 to 70 years, 43%, and remains around that period even in 80 plus. So the numbers go on becoming smaller, so there is wide confidence interval around this, but this is the percentage we got. BMI, if you look at BMI from normal to obese, there is gradient. It's increasing gradually from 36% to 39% to 43%. And of course, those who had history of stroke, they had higher prevalence of diabetes. So I'm not going to spend too much time on this, but just to tell you that scenario about treatment and control is not very good. Even though they are in Vasant Kunj, educated people, Manirka, highly educated people, but still, you see, of those people who had diabetes, only 66% were on treatment, and only 25% were controlled. So 75% of people with diabetes in quite educated area of Vasant Kunj and Manilka, they don't have proper control of diabetes. So there is a lot of room to improve. So just to compare our data with National NCD Monitoring Survey, of course definitions were different. They only used fasting blood glucose, whereas we used either fasting blood glucose or hemoglobin A1C. So some differences in age group also, but still it is good to see the difference. Our cohort had 38.4% prevalence. In their 50 to 69 years, 21.8%, but they had rural people also, so not surprising. Among diabetics, we had 93% people, they know they are diabetic. So very good awareness. 66% are getting treatment, whereas 36% are getting treatment in national survey. Controlled are 25%, I told you, and only 16% in the national monitoring survey. So that is the scenario in which we are operating. Now coming to diabetes and stroke. We always say diabetes is a risk factor. We don't say it is a causative factor. And a risk factor to the extent that it increases the risk of diabetes by 2 to 3 times, and a risk of stroke by 2 to 3 times. And once a stroke happens, those who have diabetes, they have double the chance of having unfavorable outcomes. So it is a prognostic factor as well. And remember, 1/3 patients at least with stroke have diabetes. Also, after they recover from stroke, they have higher rate of recurrence. So 1.5 times risk of recurrence of second stroke if they have diabetes. And after stroke, many people will develop cognitive decline or vascular dementia because diabetes affects both small vessels as well as large vessels. So diabetes plays havoc with patients with stroke, and therefore there is a need to control it properly. Now the question is, why don't we call it a causative factor? Hypertension, we say, is cause of stroke. Diabetes is a risk factor for stroke. The reason was that intensive control of blood sugar in DCCT trial did not show that it decreases stroke, at least not statistically significant reduction. Even after follow-up of 30 years, it did not reach statistically significant value. That is why if a randomized trial is unable to show if control of diabetes leads to prevention of stroke, then one cannot call it a causative factor. Same thing happened in UKPDS study, which you must have heard several times during the day. 3 trials in 2008, 2009, advanced, bad, and the third one, none showed benefit for stroke or even for major adverse cardiovascular events. So unless in a randomized trial you are able to show this, one is hesitant to call something as stroke, though there is something called Bradford Hill principles, which you can apply and say something as cause, even though it may not be data from randomized trial. So recently, there are some trials and meta-analyses which show that if you use these antidiabetics, you can demonstrate reduction in stroke. And one of such agent is GLP-1 receptor agonist. Three agents, which you must have discussed today or this morning, have shown to prevent major adverse cardiovascular events in high-risk patients and also relative risk reduction of 17% for stroke. So first time some anti-diabetic drugs was shown to reduce incidence of stroke. Then 8 trials, when they were analyzed together, they also showed reduced risk of any stroke, means any type of stroke, non-fatal stroke, but did not show significant reduction in fatal stroke. Maybe because number of deaths were small. SGLT2 inhibitors, which I heard this lecture just before my lecture, which has been shown in Credence trial and meta-analysis. I will come to this later. So this is the paper I was talking about, SGLT2 inhibitors for stroke and atrial fibrillation in patients with diabetic kidney disease. So it is a subgroup analysis of the trial which you must have heard since morning, the Credence trial. And look at the plot. I must spend 1 minute to explain how we look at the plot. As you can see, this is a vertical line. If something is on the left, it favors this. In this case, we are talking about canagliflozin, and this time this side is placebo. All the dots which you see, they are in favor of intervention. So probably they are favoring, or let's say they are benefiting, but still not reaching statistical significance, because the whole line should be on the left side before you say statistically significant. Only in this, which is the patients with 30 to less than 45 ml per minute of this eGFR, you see that this line is on the left side. But these drugs have a lot of effects. They have effect on blood pressure, they have effect on body weight, they have effect on, of course, diabetes, they have effect on, to some extent, on cholesterol. So we are getting this effect because of control of diabetes. And if you analyze it with another set of compounds, SGLT2 inhibitors, you will see that non-fatal total stroke, there is no effect, which is right in the center. This is from the combination of all this data. Non-fatal stroke right at the center. Fatal stroke also not reaching statistical significance because it is not towards the left entirely. But if you look at hemorrhagic stroke, this is entirely on the left hand side. So somehow, hemorrhagic stroke is prevented by using these SGLT2 inhibitors, while others are not statistically significant reduction. Similarly, if you take it with other trials, as you can see, only in cases of eGFR for less than 45 ml per minute per 1.73 meters square, you see statistically significant reduction in number of strokes with the use of SGLT2 inhibitors. This is much more clear if you take the overall data. And rest all, there is statistically non-significant result, but here only with eGFR less than 45 ml, you see statistically significant benefit. So, in this meta-analysis at least, you find a suggestion that among people with type 2 diabetes and established cardiovascular disease, taking SGLT2 inhibitor therapy may reduce the risk of hemorrhagic stroke and reduce the risk of fatal and non-fatal stroke in patients who also have more advanced chronic kidney disease. Obviously, because these are subgroup analysis from a large study which was done for different primary objective. These findings need to be confirmed. But from practice point of view, we can make some conclusions. And not to undermine prevention and remission of diabetes, patients with pre-diabetes or type 2 diabetes should be encouraged to maintain a healthy lifestyle, and if overweight or obese, lose weight so that they may prevent diabetes or you may get remission of diabetes. This was not my topic, but I want to highlight this because this is probably the most important thing which we can advise to the patients. But GLP-1 receptor agonists and SGLT2 inhibitor therapy each seem to prevent major adverse cardiovascular events in type 2 diabetes patients with established cardiovascular disease. So remember this caveat that established cardiovascular disease is very important, and that includes stroke as well. Though, as the meta-analysis says, we need more data, but one should start considering whether these therapies are actually better for prevention of stroke in patients who have type 2 diabetes, and whenever patients are at high risk, probably we should also prescribe them. Thank you very much.
Thank you so much, sir.